Okay, here we go. You tell me when you're ready.
I'm ready.
Ready.
Nice. All right, so we're going to do some shoulder evaluations here on Rachel. So some of the first things with the shoulder we can do is we can have the person actively just move their shoulder and look for loss of motion. So can you take your arm out here to the side, abduction as high as you can, raise that up, good. We could do adduction, take it across, see if she has any pain. We could do forward flexion, just keep your arm straight, and, looking for pain, looking for loss of motion. She could go backwards into extension here, something like that. We can also test external rotation for pain and motion. And we can also test internal rotation for pain and motion. And then two other important ones are horizontal flexion, just range of motion there, and then horizontal extension coming back. All right, so always good to do those both actively and potentially passively and look for pain and see which muscles are tender or have an idea of maybe which muscles are affected already with your patient. So some of the other tests that we did or are looking for here in the shoulder are thoracic outlet. So again, thoracic outlet is this area right underneath the clavicle and in front of the scapula and the rib cage where we have nerves, the brachial plexus, and the subscapular artery and vein that are coming down in this area and eventually coming down into the underside of the arm. And they can be impinged by cervical rib, a tight pec minor, tight scalenes, multiple things. So one of those tests is Adson's. And with this, I like to just keep the patient's shoulder stable. I'll pull her into a little bit of a stretch in this area, and then I'm going to feel for the pulse. So a diminished pulse is one thing you could look for. I'm going to have Rachel look as far as she can towards me, and take a big breath in, and she's going to hold it as long as she can, at least probably about 30 seconds. So we're looking for, one, they say a diminished pulse. I like to look for more pain or symptom reproduction. So if she came in with arm pain and we're reproducing her pain in this position, that would be positive. Thank you, Rachel. So again, we have her hold that a while. There's a very similar type maneuver called reverse Adson's. So same position, but Rachel's going to look the other direction, take a big breath in, hold it, looking for diminished pulse, looking for reproduction of symptoms, right? So same kind of thing. Hold that a while, 30 seconds to a minute. And again, that might indicate tight scalenes. We get in there and palpate those. A tight pec minor, we might get in there and palpate around there. See if we can find something there causative. Okay, these next four tests are for shoulder impingement. First one is called Neer's impingement, and this is impingement right underneath the acromion where the supraspinatus and other rotator cuff muscles attach on the greater tubercle, right in that area. So the patient may have pain kind of regionally in here. So Neer's person is limp, and we're just going to raise their shoulder up to full abduction, looking for pain reproduction. I've also seen the test done laterally, where you go just straight into abduction and raise up, but we're really compressing and irritating that shoulder with full abduction. And that's indicative of subacromial impingement, subacromial bursitis, subacromial tendinitis. The next one is crossover impingement, or the AC adduction compression test. So we're going to fully go into horizontal flexion, and I'm kind of pushing on her elbow. This hand's over here just kind of stabilizing her, so we're kind of compressing my hands almost towards each other. And when we do that, if she has a lot of pain right up top, that AC joint is right here, we might think we're compressing an irritated AC joint. If she has pain a little bit further in the front, we are potentially compressing the rotator cuff, so supraspinatus can show up like that, or subscapularis can show up with pain here. And if she has pain more on the back side over here, we're stretching the posterior capsule, we're stretching the infraspinatus and teres minor. So depending on kind of where her pain is, it might indicate one of those structures being related. Next one is empty can. So I'm going to have the patient arm out. We're going to go out to about 45 degrees. I'm going to have Rachel take her thumb in full pronation. She's going to push up while I push down, and adding some force there. But we're looking for her to go weak, and we're looking for her to grimace and make a painful face, right? So pain and or weakness. She may not have any pain, but she may go completely weak. If it's an old rotator cuff tear, she may have no pain at all. So weakness is something we definitely want to look for too. And I can indicate a supraspinatus tear or supraspinatus tendinitis, subacromial impingement. Last one in this set is Hawkins. So pretty similar, arm out straight. We're going to bend the elbow. We're going to go in about 10 degrees, then we're going to internally rotate. And right at that end range where the arm stops internally rotating, that's where the patient will typically have pain with impingement. So again, indicating subacromial impingement of one of the rotator cuff muscles. Nice. How'd they go?